Okay, I guess we'll start now. So welcome everyone. My apologies again, my camera is not working. I've tried everything. So my name is Pascal Lissouba. I'm with Epicentre and also a member of the IOA core team. I'm very happy to welcome you today for Birgit Nicolai's presentation on the Urgepi project in the DRC. The title of the presentation is Developing Local Adapted Measles Vaccination Strategies in the DRC. It's a very exciting project for Epicentre because it's a collaboration with IOA. Birgit, please share your screen and then we can start. Thank you again.
Yes. Hello, everyone. So as Pascal said, my name is Birgit Nicolai, and I'm an epidemiologist also working with Epicentre. And today I'm going to talk a bit about the Urgepi project. We already had a presentation, I think, which is now already 2 years ago, about the project more in general and what we're trying to do. So today I'll dive a bit more into one of the topics that we're really targeting recently, to develop more locally adapted measles vaccination strategies to prevent and respond to measles epidemics. Just a second. Yeah. So just to give you a very quick overview of the project. So it's a measles emergency response project with an operational research component that started in 2018. And then a couple of years ago in 2021, we really revised our strategy to make it a bit more operationally targeted. So the project is located in the 4 provinces in the southern DRC, Tanganyika, Haut-Lomami, Lualaba, and Haut-Katanga, where we can see regular and quite big measles epidemics. And so the overall objective of the project was to improve how we can prevent and respond to measles epidemics. And the project covers a list of activities, including preventive vaccination, strengthening surveillance that's really targeted to identifying outbreaks as soon as possible. We are also supporting biological confirmation by supporting a laboratory in Lubumbashi. Of course, MSF is leading interventions for including vaccination campaigns, but also case management. And as I said before, we also have some operational research ongoing. So the whole approach of Urgepi uses what we call a targeted approach towards high-risk or priority health zones. So that means because the area with the 4 provinces, even it's not the entire DRC, but still is quite large for us to cover. So we had to be a bit pragmatic where we are focusing our attention and our resources on. So everything's like kind of laid out in a way that we try to anticipate where outbreaks will happen and where the bigger outbreaks happen. And then we focus more on these health zones. So today, I won't cover all of our activities. I'll really focus on preventive vaccination activities, because we're using that as an example how we can improve vaccination strategies, because the timeline is a bit like longer, so we have more time to understand and to prepare. But then ultimately in the next couple of years, whatever we learn from preventive vaccination, we are also trying, of course, to apply that to the riposte, so the reactive vaccination activities. So I'll quickly talk about the evaluation that we did of preventive vaccination activities in 2021, because that kind of lays out what we're trying to do more recently. And then in the second part of the presentation, I'll talk about the development and implementation of preventive vaccination strategies in 2024 and 2025. So as I mentioned before, Urgepi uses this risk-targeted approach, like without going into too many details for the sake of time, but just to give you an idea how we do that. So in 2021, where MSF did a number of preventive vaccination activities, we identified our priority or high-risk health zones using a mathematical model that basically was run for us by the colleagues from the Penn State University. So it's the group from Matt Ferrari. And so this model basically uses information on vaccination coverage, to estimate number of non-vaccinated children, to estimate the number of susceptible children, and then combining these indicators, it gives us kind of a final prioritization. So it basically just ranks health zones in the provinces we're targeting according to priority, according to risk for large epidemics. In 2021, MSF also added other criteria. So we were focusing more on Haut-Katanga, even though just talking about risk, it's not the most high risk area in the 4 provinces, but this was like really an operational decisions, like how quickly we can reach some places from the base, which is located in Lubumbashi. And we'll get back to this, like how we identify priority health zones for the 24 activities, because actually we've been revising it since then, but it's really just to give you an idea for when we did the preventive activities, how these were identified. So in 2021, we had preventive vaccination in 9 priority health zones in collaboration with the Ministry of Health. So this was measles. Back in the days, there was not that many multi-antigen activities, but now moving forward, we'll also include more of that. So it depended a bit on the negotiation with the health zone. So what we originally had in mind was vaccinating all children in these health zones aged 6 to 59 months. In some health zones, this was not possible. So sometimes we were only allowed to vaccinate children 6 to 23 months. And in some health zones, we also had to make a selective vaccination. So basically trying to identify children based on vaccination cards for vaccination. So before being able to evaluate what the impact of our preventive vaccination was, we need to look at our priority health zones where we didn't do the preventive vaccination. So we had not the capacity to cover all of them. So here you can see 10 unvaccinated priority health zones from 2021. And you can see that 9 of these actually experienced quite large epidemics. So you can see the identification of health zones in high risk of measles epidemics worked quite well. So with one exception where no measles epidemic was detected, the others were quite severely affected. So now if we look at 9 priority health zones where we actually were able to implement the preventive vaccination, you can see that like 6 of them remained really quiet. So we can say that likely with the preventive vaccination, we managed to prevent large epidemics in these 6 health zones. However, in 3 of the health zones, despite preventive vaccination, we observed medium size or even in Manono quite big actually epidemics. So you can say statistically, we did have an impact, like reducing the risk of large epidemics. Like here we define them as more than 500 notified cases from 90% to 33%. And also we see really a difference in the median attack rate, like looking at these zones from 400 per 100,000 in the non-vaccinated priority health zones to about 100 in the preventive vaccinated health zones. Maybe just to dive a bit into what happened in the 3 health zones where we had epidemics despite the vaccination. So first of all, we wanted to know, are these actually measles epidemics or something else? But we can say they were all biological confirmed. They all occurred in the age groups that were actually supposed to be vaccinated. And then when we look at the geographic distribution here on the side, we can see, well, in 2 health zones, it was more like pockets of health areas in epidemic state, while in Manono, really the entire health zone was affected. And actually, we did vaccination coverage surveys in 2 of the health zones, which was Manono and Kinkonja, and they actually confirmed what we then already suspected. So it's not a problem that we did a successful campaign, but then something else popped up. But it's really, we did have quite low coverage, which was really disappointing. And brought us to the conclusion we really need to work on our vaccination strategy, because the one fits all and we just go there and we roll out the machine doesn't seem to work in all of the places. Okay, so for the activities from 2021, we concluded, yes, preventive vaccination is a good strategy targeted to the high-risk health zones. So it can really help protecting populations. And it can help also plan ahead. So preventive vaccination can be done during the dry season. And so we do not need to respond to epidemics then in the rainy season. But we can also conclude that in some places, actually, we really need to work on how we implement the vaccinations. So we need to work on locally adapted strategies that are acceptable to the population and that overcome some of the barriers. So for the activities for 2024-2025, the recommendations were then to simplify the criteria to select high-risk health zone. As I said before, there were so many other factors coming in that it wasn't really focusing on epidemiological risk anymore. That we need to develop better vaccination strategies that are targeted either to these geographic areas, as you've seen, like these pockets that are at risk of epidemics, or also could be to population groups with low vaccination coverage. And then in discussion with Simon's group, we decided also to include an IOA approach to really better understand what the immunization barriers are and how can we improve vaccination coverage. So now for us, right now is a really exciting time because we moved from the recommendation to the activities, and actually we are currently in a Ankoro health zone in the Tanganyika together with members from the IOA team, starting our new package for the preventive vaccination activities. And so this is now what I'm getting at. Unfortunately, at this stage, I have no results to present. It's more like the overall layout, but I think it will be really interesting to discuss. So first, how then for the 2024-2025 activities, how did we proceed in selecting the health zones for preventive vaccination? So instead of this mathematical modeling with the operational additional factors, we tested some other more simple algorithm. And in the end, so here you can see on this graphic, for 2021, for example, the proportion of health zones among the prioritized health zones and the proportion of health zones among the non-prioritized health zones that experience a large epidemic. And you can see that for 2021, this prioritization worked quite well. So a larger proportion of health zones in the priority group experienced these large epidemics. And then we also had slightly modified criteria in 2021, 2022 until the end of 2022. So all of these worked the first year better than the others. Here was less significant. But when testing, I'm not showing the entire list, we found that actually using historical vaccination coverage, and specifically it's actually from a DHS survey in 2014, allows us to even better identify health zones at risk of large epidemics. So by just saying, based on the vaccination coverage data, if a health zone had less than 40% coverage, back in 2014, the risk of having a large epidemic is very high compared to health zones that had higher than 40% coverage, where the risk is significantly lower. It still means it's not a perfect classification, but at least with the resources that were available, we can focus on the health zones that are very likely experiencing large epidemics. Of course, I mean, we're often in discussion why we're using this old data, because this has been an independent survey and that had a design that really allows us to have quite reliable estimates at health zone level. Of course, we are open to whatever comes available to use also the newer estimates, but we would need to do this similar evaluation first to see that this works well. And then, so this still leaves us with about close to 20 health zones that are identified as priority health zone. So in the moment, we don't have, as MSF, the capacity to vaccinate all of these health zones in preventive vaccination. So together with the Ministry of Health, we've been discussing the choice of health zones that face different challenges. So exactly, we were looking at identifying 2 health zones for 2024 and 2 health zones for 2025. And we decided to try to target different problematics. So we're looking for one health zone that had really issues with access difficulties. So we can try to figure out ways how to overcome these. We're looking for another health zone that is dealing with insecurity and like problems in vaccination coverage that are related to this situation of insecurity. A third one, which has more mobility of the population, which also is another challenge in achieving and maintaining high coverage. And then the fourth health zone, we've been looking at characteristics such as high comorbidity. So for example, if a population is already dealing with, for example, high malaria incidence, and then we're coming and trying to vaccinate them against measles, then there may be less motivation actually to get a vaccine for something that is not a primary health concern. So we've been looking at measles and malnutrition in that instance. So in the moment, we've been starting with the first health zone, Ankoro, which was selected because of difficult geographical access. So now, as I said before, we wanted to test more targeted approaches. So we want to avoid revaccinating again and again the entire health zone, because what we suspect is happening is that often we are just revaccinating the same children, so that areas that already have high coverage within a health zone, well, they will be the ones again being vaccinated and again having high coverage. So how can we geographically already identify the areas that have very low coverage, and then really specifically target these and the other geographic areas within a health zone that are already well served by vaccination? Well, we don't need to include them again in these activities, which can be quite costly. And also really there's no point revaccinating them if they've been already vaccinated by preventive vaccination, routine vaccination, and maybe even a reactive campaign. So I think in some settings, they've been well served. So the questions we are trying to answer to identify the health zones. So how can we avoid revaccinating children, but also how can we find and target the non-vaccinated children? So just to show you some examples, like this is also all the data from 2021 and 2022. So when we do vaccination coverage surveys, we can observe that vaccination coverage is not homogeneously distributed within a health zone. So you can see in blue areas here that are quite well served by vaccination with a coverage above 95% or between 80 and 95%, which we still consider as acceptable. And then some areas, some pockets that really have extremely low coverage. So basically, if going back to this health zone with another vaccination activity, then we would hope, to focus on these areas that have very low coverage. Of course, this varies between health zones. So kind of relates also to what we've seen from the epidemic profiles, that sometimes it's more like very small, concise pockets. In other health zones, the problem may be a bit more geographically wider. So we need to differentiate that, and we also need to identify these pockets. And so this we can do with vaccination coverage surveys, and particularly surveys that allow to have this like finer spatial distribution. So that's why, like in our strategy to develop the locally adapted vaccination strategy, we are starting with community-based vaccination surveys to identify these pockets. And then we're working together with the IOA team to better understand what actually causes these pockets. So what are the barriers to immunization and how can we overcome them, particularly in these areas where coverage is so low? And then this will be integrated to develop locally adapted strategies. So together with the MOH, together with the community and other partners present, we are trying to identify what these strategies are, what the recommendations are. So what can be done by MSF, what needs to be done by the ministry, what can be done by other partners. And we try to move from this evaluation and operational research to something actionable. So this includes then, of course, the MSF vaccination campaign, but can also lead to recommendation for routine immunization or future campaigns by other partners. And then as part of the study, I also want to highlight that after the implementation of the locally adapted strategy, we also want to evaluate these.
Sorry, Brigitte, you're muted.
Sorry, I think I'm back. Can you hear me now?
Yes.
Okay, good. So basically, so we are not only satisfied by having these pre-vaccination assessments and then trying to come up with something better. We will also thoroughly evaluate our new strategy to see how much we improved compared to the surveys that we previously presented, where we had very low coverage, and to see also where are still, the remaining barriers. So during the implementation of the vaccination strategies, we will already integrate the vaccination survey at the vaccination sites. So where we just ask very basic questions about the vaccination status. And so at this stage, we are basically just trying to assess whether we are vaccinating non-vaccinated children, or basically if everyone that comes to our vaccination activity has already had the opportunity to be immunized before. So we'll ask about vaccination status. We'll ask also about natural infection. So this gives us a feeling of, are we doing well enough targeting these non-vaccinated children, or are we just doing the same thing what we've already done during previous campaigns or for the routine vaccination? And then we'll have a second vaccination coverage survey, which will be done again in the community. So this is the same procedure as for the baseline survey that we used to develop the strategy. I mean, of course, this time we'll be focusing, if not the entire health zone has been vaccinated, to the health areas where activities were covered out, and then we'll assess the coverage that we reach with these activities. So this will be all focused on measles, but of course, because we are also considering multi-antigen campaigns, we also, both in the baseline survey and in the evaluations, we will include questions about other antigens. So in conclusion, we can say that, well, preventive vaccination is powerful to prevent measles epidemics, but we need these more locally adapted strategies. So here we are testing in the moment, it is really just happening, the use of baseline vaccination surveys and the IOA approach to inform these vaccination strategies in real time. We'll be evaluating the vaccination activities with two types of vaccination coverage surveys, one at the moment of vaccination, one in the community after the vaccination. And as I mentioned before, we will have 2 high-risk health zones targeted in 2024 and 2 high-risk health zones in 2025. And as I mentioned earlier before, like here in the set of preventive vaccination, we have a bit more time for the baseline evaluations, for the development of the strategies. But then also we will need to think about how we can develop tools that are maybe quicker to implement, really in the setting, okay, we have an alert, we are trying to do a reactive vaccination campaign. So how can we at least get some basic information that is necessary to also improve our vaccination activities? But this is a bit further down the line. Okay, so I would like to thank particularly the Urgepi team, the MSF team, the colleagues from Epicentre. I saw Pascal is here and Emily. So Emily has been helping very much with the protocol, and then of course our partners from the Cellule d'Analyse Intégrée in the DRC, who are currently on the way to Ankara to join the Epicentre team. So it's the first time we will manage to work that closely together. So it's a very exciting time. I think we'll be all learning from each other a lot. Of course, the Ministry of Health and the DRC, who are on board with this both study, but also operational implementation of the vaccination activities, the INRB in Kinshasa, the Grand Laboratoire in Lubumbashi, who are in charge of confirming measles epidemics. And thank you so much for your attention, and I'm looking forward to your questions and the discussions.
Thank you so much, Birgit, and congrats to you and the team. This is really impressive. Oh, there's a question from Norche. I'm sorry if I mispronounced your name. Please go ahead and ask your question.
Thank you very much for the presentation. Very interesting. I had one question. Maybe I missed it. You touched briefly upon it, and maybe you mentioned it actually. But having been based briefly myself in Manono also, I was curious if what your explanation was for the outbreak there, despite that you had targeted it. Was it just the low coverage in the end, or was there something else? Curious to hear your answer. Thank you.
No, Manono is a very interesting and a very specific setting. So because in the vaccination coverage survey, even though we don't dive into all the details as with the IOA approach, but we still ask for some reasons for non-vaccination. And it turned out that Manono had a very high refusal rate. So it's not that often that we just see purely refusal, leading to this low coverage. Sometimes it's like part of many reasons. And it was more specific in the sense that there was issues related to MOH activities, so the distribution of plant peanut, where apparently not everyone was equally served, or even there were some rumors about plant peanut being sold elsewhere, and the population really went in opposition to the government activities, so refused vaccination because it's part of that bigger machine. It's the first time that I personally saw these really strong resistance out of political reasons. As I mentioned before, currently we're in Manono, so we don't yet know from the IOA approach where this really leads us. We only have these very standardized reasons for non-vaccination, and also again, so it's just neighboring to Manono, we get a high refusal rate. This time it seems a bit more linked to religious reasons. But still, again, even in Ankoro, this story of plant peanut and mosquito nets is coming up. We did have just to also maybe put the broader context, because these are two examples of refusals. Other areas where a lot was just the timing of the vaccination surveys, vaccination activities that were bad. So people in the reasons, it was mainly, oh, we didn't have time, we were not there. But because we didn't dive into more details, we also question a bit that response, whether that's just, an easy answer to give if you don't actually want to talk about it. So it will be interesting this time, also comparing what we got with our very predefined list and then what the IOA approach, in the discussions with the community and the healthcare personnel really brings up, whether that fits.
Thank you.
Thank you, Birgit. There's a question from Grazia in the chat. So she says, for future IOA, would it be relevant not to only look at barriers or hesitancy experienced by the community, but also local factors that can enable access? Also, the outbreak are mainly measles or other preventable diseases. So maybe if you want to start with the...
Yeah. So for the first one, no, indeed, in the list, for the vaccination coverage survey, we have a list of 20 reasons. I mean, the question is asked in an open way. So in theory, the person can answer anything, and then the interviewers try to classify them into 20 answers, but we still have an open answer. So if anything's not covered by our categories, we can retrospectively classify. And so one example also from Ankoro, because I'm literally just looking at the data, what we haven't included in the list is, for example, the decision responsibility is with the husband. So this is something to point out, and that was not included in the list, but we can do that retrospectively. In the list, we had a group which is one part related to refusals that we talked about now for Manono, but then also we have an entire list of these issues related to geographic access. So if the health site, the vaccination site was too far, if it's difficult to get there. And then, of course, with the teams on the ground, we'll also try to get a bit for example, comparing household locations to healthcare center locations. So these are kind of these things where we can look at whether it's distance, and then of course in the discussions like to dig into the geographic access of vaccination site. Like also to go back to Ancoro, like originally this was our hypothesis about the main problem in the health zone. It's just like now by chance it seems to add on this additional complication of the refusal, but originally what we thought it would be was the geographic access. So we will be in for the IOA approach, like digging into these issues. Yeah.
Thank you. Grazia, do you?
Oh, sorry. Yeah, and for the
Yeah.
other question, it's true we are focusing on measles, but like many of the questions are framed in a more general way to include immunization in general. So it's, even though like the how you say, like the immediate goal is to develop these preventive measles vaccination activities, we are also of course trying to get recommendation for immunization in general. So if there are things popping up about other vaccination activities or vaccination just in general, then we also try to make recommendations on that.
Thank you. Any other question? Yes, Anna?
Thank you very much for your presentation. Very interesting. I was wondering, what is your collaboration with other vaccination programs or activities? I personally, I will be a little bit more involved in the Mpox vaccination activities that will ideally start soon. And I think those also need to be accompanied with additional indicators from the community, how well the vaccine is perceived, accepted, what are the challenges, the barriers. So do you think this, your let's say approach can be easily taken over or scaled to other diseases? And also if you could explain how much effort is required, both in terms of human and financial resources. Over. Thanks.
Yeah, thanks. No, I mean, it's a really good question, and I admit we're still also learning, because it's true when we started as Urgepi, you know, the reflections of the project, we were very narrowed down to measles, and it's been like recently, like in discussions and how we set that up, that also we realized the demand to make it larger, and actually from measles to at least including the other routine immunization antigen is really quite straightforward. But having to say, like for these ones, we are all like looking at children. So like the age group for the vaccination coverage survey, the age groups for, you know, understanding what the barriers are that we have to, you know, basically ask the parents, but parents of children in that age group. So then it's easy to just piggyback things. Once it gets like to vaccination programs that would need to target different age groups, I think then it becomes more complicated, and then you may want to keep things separate, even though there may be still some things that are generalizable. In terms of efforts, yeah, I can't yet tell you exactly, because it's the first time we are implementing them. I have to say, for the vaccination coverage surveys, like we are also discussing, like usually we do have at least one epidemiologist who then leads a team of field investigators. So I would say these are like 20 people that then, you know, move around in the health zone, but there needs to be a qualified epidemiologist who can actually train them, who can do the sampling, who can, you know, send them to the right locations, the selected villages, etc. And then, of course, you need to have the logistics with it to have these people move around either by cars or motorbikes or whatever, depending on your settings. It depends a bit, and maybe Simon's team, they will show us better. Like for MSF, the vaccination coverage surveys themselves can become quite costly. MSF OCP, it depends a bit on how much you already have. So for example, if you're working in a health zone where you have continuous presence and then you just dispatch people from your base to other sites, then it's okay. For MSF, it's often we need to completely move to the health zone with an admin team, with the logistics, with the cars and everything. So it adds on to the costs. But I think a vaccination coverage with these geographic details for us is between $15,000 and $20,000. For the IOA approach, so this is handled by the Cellule d'Analyse Intégrée, so they're better placed maybe to answer that question, even though I have a rough idea. And then the vaccination coverage survey at the vaccination site, like that one is the least costly one, because you're basically just adding a person that you probably already trained for your baseline survey to one of the vaccination teams, and they take notes. So this one is really at nearly no cost. And then the follow-up vaccination survey will depend, of course, on the scale of your vaccination. So this time, because we're doing it for the first time, we're like really full hands on board. We have a huge team. With like me following from Paris. I have a colleague, Catherine, who joined also the IOA team for a month on the ground with the epidemiologist of the project who has been with them. And then, of course, also for MSF, it's a huge machine. We have a health promotion officer, like manager, because we're really trying to improve how we communicate around the vaccination activities. We have a medical person following or planning the vaccination activities, and also someone more what we call a chef de projet, more in charge of the overall rollout, like coordinating the logistics and the negotiation with the health zones, etc. But then, of course, because this is our first learning experience, we try to downscale it as much as possible and to make it a lighter version of it. So we'll see. But I mean, we have to, like, once we do the capitalization of that, also to look into how we can make that easier to be implemented at a wider scale.
Thank you, Birgit. Any other question? I have one. I was wondering if you could let us know a little bit more about how the IOA collaboration is organized, and maybe the kind of maybe extra procedures you've had to do at the institutional level. I heard you talk about having a protocol written, things like that. Could you give us a little bit more details?
Yeah, so I mean, it's Pascal, you correct me, but I think it's the first time that we really have this very official collaboration between Epicent MSF and the Cellule d'Analyse Intégrée, so the IOA team in the DRC. And so, well, for the collaboration, what Epicent MSF requested was to go through an ethical review board, because we're a bit also in the gray zone, because the IOA approach, the Cellule d'Analyse Intégrée, have been doing their assessments in the DRC for quite some time. But usually, I mean, as the name of the activity implies, it's part of an outbreak setting, and here we're kind of in this operational research setting, which it's kind of this gray zone in between. Like, we're trying to immediately respond to an outbreak situation, or now we're actually doing research. And so to be on the safe side, we opted for having a protocol that then needed to go through ERB approval on the MSF side, but also ERB approval in the country. For the collaboration itself, it's true for us, it's a bit on an ad hoc basis. So we are also trying to figure out how that works. So MSF Epicent is integrated in the Cellule d'Analyse Intégrée, as, like in this case, as part of a member. The Cellule d'Analyse Intégrée is, under the umbrella of the Ministry of Health. So in the moment, the team that is joining our MSF Epicent team in Ankoro is having a lead, so Fanny, who is part of the Cellule d'Analyse Intégrée, but also have colleagues integrated from the Ministry of Health who are joining the team and helping, with the assessments and the recommendations. And then, on the Epicent side, in this case, we have 2 epidemiologists and 1 health promotion manager, but it should be just like 1 epidemiologist, I think would be fine. In terms of we don't even have an official agreement signed. It's been done with communicating with the colleagues, like also from the Ministry of Health, by validating the project aim and what we're trying to do. It's probably also a learning experience, like for the next activities, and then maybe Simone and her team will have more suggestions, like how we can better formalize these kind of things. And because as usual, both from the Ministry of Health side, but also from MSF side, like we also have always these moving chronograms, like the moving timelines of activities. So for this time, I think we're quite good, but it's true, it's not always not always obvious as soon as you get people from many institutions on board, how to get everyone to the same place at the same time, and that fits also to other activities. So one thing we're often struggling with is then like competing vaccination activities. Of course, we need to fit into, whatever is happening in the health zone. We can't just monopolize the health stuff for then our vaccination activities. So a lot of things to take into account. And as I said, we're learning. We can probably in a year time, we can have another presentation of how things went and how we can improve.
Okay. So for now, it's 24-25, and then so 4 health zones that are planned on this setup.
Exactly.
Urgepi with Kai.
If everything goes as planned. So we're a bit so 1 health zone, we managed to secure the fundings. For the 3 other health zones, we're close to securing the funding. If everything goes well, this will happen. If not, then maybe we have to downscale a bit. So, but the wish and the plan in the moment is to have these 4 health zones, and then do a capitalization around that, and then see how first of all, how well it actually worked, and then how could that be like transferred to other places, like also independent, of course, from MSF. It's not just then a MSF approach. So we would like, if it actually works, then we would hope that that could be applicable to other settings. But then again, like we said before, then we also need to think how to make it affordable and feasible with the capacities that are available.
Absolutely. Great. Are there any other questions? So no, so maybe we'll finish early today. I don't know, maybe Marie-Amélie, correct me if I'm wrong, but I think this is the last meeting before summer, correct? And then
so I want to say it is. The real answer is I'm not sure, but I haven't seen a new invitation, so I guess they will start again by September.
Okay. All right. Well, thank you so much, Birgit, and good luck on the rest of the
Thank you.
on this huge undertaking. And yeah, we can't wait to hear how everything worked out. So maybe we'll meet in a year's time, hopefully. And thank you everyone for joining. And so we will see you in September. Have a wonderful summer or winter, wherever, depending on where you are. Bye. Oh,
Bye.
Emily, is that a hand up or a wave? Okay, it's a bye.
Oh, just clapping.
Yes, and again, thank you, Birgit. Thank you so much. And thanks, everyone. Thank you. Bye-bye.